Dean Vickers and your new chair, Dr. Chen. Appreciate the invitation to come and speak to you today. Before I came, I spent some time in the last few months looking up Dr. Lyons' history, and you've heard some of that, but I did want to try to tie that into what I'm going to be talking about today. And so, as you heard, Dr. Lyons was chair here at UAB from 1950 until his untimely death in 1965. And as you heard, he had a tremendous interest in bacteriology, and really came at surgical treatment of diseases from trying to understand the basic science of microbiology, and was a leader in being able to learn what he learned in the laboratory and apply that to a clinical situation. This was the time of antibiotics during World War II, and you heard about his treatment of burn patients from the Coconut Grove fire, and that continued that in the Army during World War II with some burn victims there, and really revolutionized the treatment of burn care. When Dr. Lyons came here to Alabama, to UAB, as the chair of the department, it was noted that he brought a new attitude on the scene and a new tradition was born. And I think that approach has been carried on by Dr. Bland when he came here to run the department about, 16, 17 years ago, and really revolutionized and again changed and raised the bar with bringing basic science research as being an important part of both the education and mission of the department. And I'm certain that tradition and that trajectory will continue with Dr. Herb Chen. Dr. Lyons was a recipient of a number of awards. He was chair of the Board of Regents of the National Library of Medicine, chair of the AMA section in surgery, and he was appointed to the National Advisory Heart Council by the Surgeon General at the time, Luther Terry. And here is a picture of Dr. Lyons receiving a Doctor of Science degree here just about 3 weeks before his death. But I think that his life embodies the model that we have all adopted in academic surgery, which is to extend our basic science understanding about the biology of the diseases that we treat and use that information to advance patient care. So I'm going to talk to you today about some of the insights into the breast cancer biology and the things that we have learned about breast cancer biology and how that might affect patient care decisions. And it really, if you understand the biology, you can make the right decisions about patient care. And in breast cancer in particular, it's a great example of how understanding the biology has changed and allowed us to evolve patient care. I have to say that sometimes when in other fields, it's driven by other discoveries which are just as valuable, such as vascular surgery with new innovative technical understandings and approaches that allow you to do things differently, and it changes the indications for certain operations. But in breast cancer, it really has been about the biology of the disease. And one of the first things that really changed the way we treated breast cancer was understanding patterns of gene expression. And this is how it's gone on now for 100 years. You took a breast tumor out, and then pathologists looked at it under the microscope and said, okay, well, it forms glands, and this is what the stroma looks like, and this is what the cells look like. And based on that, they characterized histopathologically the tumor and came up with a prognosis and a plan for treatment. But to really understand cancer better, you need to go down to the molecular level and begin to understand more details about the pathology and the molecular changes that are occurring in those tumors. And that is now beginning to inform how we treat patients with cancer. And this is one of the earlier studies that began to show that different types of breast cancers could be grouped into different types of cancers based on the patterns of gene expression. And then if you studied those different patterns of gene expression, it actually correlated with differences in overall survival of those patients, again, demonstrating that the molecular signature, gene expression signature of those different cancers has implications for the prognosis as well as the treatment that you'll see. And this is one of the tests that are used, the Oncotype DX test, where they take from the archival specimens, they PCR out some quantitative analysis of gene expression for about 21 different genes, and then they take those relative expression patterns of those genes, and they come up with a score to decide what the prognosis is of those patients. And that the outcome of those patients is influenced by both the stage of the disease, but also the recurrence score based on this pattern of gene expression for ER-positive cancers. Based on those scores, you can stratify the risk about patients that are most likely to get a recurrence, and low-risk patients, medium-risk patients, and those with a score that works out based on this pattern of the expression of these 21 genes greater than 31 is considered a high-risk patient. Now, this is prognostic, but in fact, it can also impact treatment. What's been shown here, if you take all these ER-positive patients and you treat them with chemotherapy, you get a very marginal effect in overall outcome. However, if you then look at these response to chemotherapy based on the patient recurrence score, meaning the molecular profiling, which is implying a good prognosis, intermediate prognosis, or a poor prognosis, you find that it's this group of patients with a high recurrence score that are the ones who are receiving and driving the benefit in here. And so the majority of patients don't need chemotherapy for ER-positive cancers. There's no good response, doesn't change survival. But in those patients who have a high recurrence score, it makes sense to give them chemotherapy. So we're actually now getting to the point where we can use these patterns of gene expression to predict outcomes and response to chemotherapy. So that's one example where understanding the biology has had a significant impact on care of breast cancer patients. The next area I'd like to tackle is an area of current view of what to do about nodal metastases. And obviously taking care of breast cancer patients has always involved a discussion and understanding of the patterns of nodal metastases. And I want to talk about 3 recent studies that I think are important to understand and review the data, which has had an clinical impact on the treatment of breast cancer patients. The first one was published in the New England Journal, and is the effect of occult metastases on the survival in node-negative breast cancer patients, so clinical node-negative patients. And to cut to the bottom line, what they were able to show by doing fine, detailed analysis of the nodes from these patients and using IHC to find just single cells, that if you have occult metastases in those patients, it will actually affect survival if you look out here after 10 years. And overall disease-free survival was statistically significant of a few % between occult metastases detected and occult metastases not detected. So here's an example where the conclusions were that the occult metastases are predictive of a greater likelihood of recurrence and reduced disease-specific survival, which is about 1% at 5 years. So then this is the important part about taking data and then saying, now how do I apply that to my practice? And their conclusion, which is I believe correct, is that this is of really limited clinical significance. So we shouldn't be doing this. We shouldn't be looking for single cells and doing excessive analysis of these lymph nodes, because if you find those people that look negative by regular H&E and you do detailed analysis, you're going to change the prognosis by maybe 1% at 5 years, and it's clinically not worth it. And this is an important lesson, and I applaud these authors for stating this. Yes, they found a significant clinical difference. It was less than 0.05. But what is the clinical significance of it? And I think often we don't do that enough in medicine. We find statistical differences, and we therefore jump to the conclusion that we should be changing our treatment because of it. The next 2 studies I'm going to talk about were extended from Z11, and there are a lot of offshoots from this study, but I'm going to talk about the 2 main studies that were published on Z11. This one that was published in the Annals of Surgery, looking at these patients from the Z11 trial. So what was Z11? Well, this was an American College of Surgeons Oncology Group study. There were 115 sites that participated and enrolled patients from 1999 to 2004. They were looking at women with T1 and T2 breast cancer. They had to be clinically node negative preoperatively. And then at the time of surgery, had 1 to 2 sentinel lymph nodes, which were positive for breast cancer. So these were now clinically node negative, but pathologically node positive breast cancer patients. They had 1 to 2 positive sentinel lymph nodes. And those patients were then intraoperatively randomized to axillary node dissection versus sentinel lymph node biopsy only. And then all patients were treated with lumpectomy and followed up whole breast radiation. And this shows the number of patients and how they stratified. There were 891 patients that were randomized, and you can say, you can go from intention to treat to actually what treatment they received, and it was pretty good, pretty well balanced. Not a lot of patients crossed over. They followed these patients for a median of 5 years. They looked at local regional recurrence in this study. Sentinel lymph node group, 7 patients, local recurrence 1.6%, axillary node group 3.1%, not statistically significantly different. So there was no difference in recurrence rates for those patients, identical patients, who then went on to have an axillary node dissection. The important point here is that 27%, so about a quarter of the patients who did have an axillary node dissection, additional cancer was found in other non-sentinel lymph nodes. So if you think about that, patients are randomized, that means in people who had a sentinel lymph node biopsy only, a quarter of those patients had cancer left in their axilla that was not removed, and there was no difference in recurrence rates. Okay, so the naysayers say, well, look at what about distant survival? So this was published in JAMA a while later, and here is showing the survival of the axillary node group compared with the sentinel lymph node only group, same group of patients now, looking at overall survival. And as you can see here, axillary dissection and sentinel lymph node alone, alive or alive and disease-free, no statistical difference. And when you look at the hazard ratio, both of these confidence intervals of sentinel node, this would be, if they were on this side of the line, would be sentinel node alone, favored sentinel node alone for survival. This favored axillary node dissection. There was actually no statistical difference between those who had an axillary dissection and those who did not. So no impact on overall survival. And I often tease the friends of mine that favor axillary node dissection to say, you know, there's actually a trend to survival improvement if you don't do an axillary node dissection. So the conclusions from this study were that there was no difference in the survival when you compared these node-positive patients who had sentinel node only versus axillary node dissection. Again, no therapeutic benefit for axillary node dissection. And they conclude, and there have been subsequent studies that have demonstrated this, avoiding an axillary lymph node dissection does in fact decrease axillary complications and lymphedema. So there are some caveats to this. All patients who were treated under this regime were T1, T2 tumors. They were all treated with lumpectomy, and they all had postoperative radiotherapy. So some questions remain from this. First, can sentinel lymph node only be applied to patients who are going to have a mastectomy? Could you extend these findings to apply to patients who are not undergoing radiation or only having partial breast radiation? What about patients who have T3 tumors who get treated and are downstage with neoadjuvant chemotherapy? Do we need to be doing axillary dissections on those patients? And clearly the answer to these questions requires additional study, but I have to say, from my perspective, this idea that axillary lymph node dissection needs to be done to prohibit distant metastases, these arguments begin to sound less like scientific arguments and more like the kind of debates we're seeing in our presidential election. You know, the idea of axillary lymph node dissection resulting in a therapeutic improvement in survival is a lot like saying that we're going to fix the problem with illegal immigrants and terrorists coming into the country by building a wall between the US and Mexico. Of course, we all know that no one doing any harm to the US ever walked across the border from Canada. And it's a lot of the same kind of thought process that, you know, somehow taking these axillary nodes out we're going to stop this cancer from spreading elsewhere and causing metastases. And I think we need to look at the data objectively and make better decisions about the treatment of our patients, because there are risks associated with doing some of the things that we do in surgery, and we need to be cognizant of that and look at it from a scientific perspective and not make assumptions that clearly were not right, because they did Z11 thinking that they'd find a difference, and they didn't. Okay, the biologic considerations related to radiotherapy. And here's sort of a summary of the background behind that. When you do a lumpectomy on a woman with breast cancer, recurrences tend to occur within 1 or 2 centimeters of the lumpectomy cavity. When you molecularly profile those cancers, they tend to look like the original cancer from a molecular standpoint, implying that it is in fact a recurrence. They also tend to occur earlier after lumpectomy. However, tumors that occur in the ipsilateral breast that occur in other quadrants of the breast are likely new primaries, and they are as likely to occur in this other quadrant distant from the lumpectomy site as they are to occur in the contralateral breast. And they also tend to occur late, and often molecular profiling would indicate it's a different primary. So the logic is, why radiate the entire breast if you can just irradiate that part of the breast? Because the whole goal of radiation is not to cure a secondary cancer, otherwise you'd be radiating the contralateral breast. It's to inhibit the recurrence that's actually occurring from the lumpectomy. So whole breast radiation is usually defined by doses of 40 to 50 gray. The treatment occurs over 5 or 6 weeks, and then you get a boost of 10 to 16 gray to the lumpectomy bed. Accelerated partial breast radiation are usually doses greater than 2 gray and the treatment course of less than 5 weeks. And there are a couple different ways that accelerated partial breast irradiation is done. One of the ways that was done for many years, we don't do this anymore at Iowa, but they had in the past, was to use something like the mammocyte to use brachytherapy to treat the lumpectomy cavity by putting in a catheter. This was refined by doing multi-catheter interstitial brachytherapy. There are techniques to use 3D conformal radiotherapy to better regulate the beams and where the radiation is being directed. And then there's the intraoperative radiotherapy. We use the Zeiss at Iowa, and we've been doing this for about 5-6 years now, where we do intraoperative radiotherapy, which at the time of the lumpectomy, you insert a probe into the breast and give the radiation dose intraoperatively, and that's the only radiation that the woman gets. So I'll give you a little bit of unpublished data here from our Iowa series. Our patients that were enrolled were over age 50 years. They had to have T1 or T2 tumors. They had to be ER positive, and then later was refined to be ER and PR positive. They had to be clinically node negative, and they did not receive any neoadjuvant chemotherapy. And this shows some of the data from that paper we're putting together. Bottom line is, when we looked at all patients receiving intraoperative radiotherapy versus whole breast radiation, one of the key differences is that was statistically different was the distance that those patients had to travel from the University of Iowa to receive their radiation. And those patients who had whole breast irradiation lived significantly closer. So we controlled that for age of the patient, other clinical parameters, stage, and other things that might influence their ability to travel. And in fact, the significance became even greater. And so this intraoperative radiotherapy is actually probably likely a good option for women in rural areas like a state like Iowa, where they have to travel long distances to get whole breast irradiation. And this is an attractive option for particularly older women who live in rural areas and have difficulty traveling. So I want to talk now a little bit about the expanded use of neoadjuvant chemotherapy. Neoadjuvant, for those of you who aren't oncologists, is a fancy word to say you gave chemo first, and then you did surgery. So neoadjuvant is just giving chemotherapy before surgery. Here's a woman I took care of. This is an MR, and here is a woman who has a locally advanced breast cancer. She has some nodes. Here you can see a large mass in her breast that was evaluated by core biopsy. Here she is after chemotherapy, and she ended up having a complete pathologic response, but you can see from the MR, it was completely clear prior to surgery. So this is really changing the paradigm for how we treat breast cancer patients. There's potential advantages of using neoadjuvant chemotherapy for breast cancer. The first that has been described is that there's an increase in the use of breast conservation. So if you get a good response, you can convert women who otherwise would need a mastectomy to the ability to have breast conservation surgery. There's also the ability to monitor response. We've had a couple examples where women don't respond, they change the chemotherapy, and now they get a response. So being able to monitor the response, whereas if you've done surgery first, there may not be any tumor anywhere to monitor the response, and so in some ways you're flying blind with your response for chemotherapy. There's also the potential to convert patients who are clinically node negative. So people who have positive axillary nodes, when they present, they get chemotherapy, they become clinically node negative. What's the rationale for now restaging them and treating them like a clinically node 0 patient? So I want to talk about 3 studies, one of which is ours on neoadjuvant treatment. The first one was this, published in Clinical Cancer Research, that was one of the first papers to note that there were different subtypes responded differently to neoadjuvant chemotherapy. And is shown here pathologic complete response in 45% of patients who had HER2 and basal subtype of breast cancer, whereas relatively low complete pathologic response in patients with luminal type of tumors. The other interesting thing that this study did in this report is they looked at the difference between histopathologic prediction of prognosis and outcome in those patients compared to molecular profiling. And this is the one where they use the pathologic variables, and this is showing just use of molecular classification. And as you can see, the pathologists that have been doing this for hundreds of years, right, they did a good job. But molecular profiling had the same predictive, pretty much the same predictive capacity. So at least it helped reassure us that basing our decisions on the molecular profiling at least was tracking somehow very closely with what we had been doing traditionally by standard histopathologic classification of breast tumors. So the conclusions from this study were that basal-like and the HER2 subtypes are more sensitive to chemotherapy. A pathologic complete response, PCR, pathologic complete response was achieved in 45% of the basal and HER2 cancers, but only 6% in the luminal subtype, molecular subtypes. And the other important conclusion from the study was that molecular characterization was as good as the clinical characteristics and histopathological characteristics, and did not add to the predictive capacity at this point. The next study I want to talk about was published in the Annals of Surgical Oncology, which again looked at the impact of breast cancer molecular subtypes. And what they did was they began to evaluate patients before and after chemotherapy. And one of the things that they found was that the pathologic post-treatment end stage, as an example, was highly significant in predicting outcome of those patients. And in many ways, the post-neoadjuvant chemotherapy was more predictive of their outcome than their staging before chemotherapy, implying that we should be restaging our patients and basing our treatment on what their stage and characteristics are after treatment. So the molecular subtype did predict local regional recurrence, with basal having the highest local regional recurrence. But the post-treatment T-stage and end-stage was more predictive of local recurrence than the pre-chemo stage. And then this last study I want to just briefly go over, which was published in Dr. Bland's journal. We struggled for a couple of years to get this published, and Dr. Bland, maybe as a personal favor, allowed us to publish in his journal. But we got a lot of pushback from this, although subsequent studies over the subsequent several years confirmed these data. So it was a small number of patients. My own personal view, I've always been at places that had small volume. I've never been at MD Anderson or Memorial. But you treat 70 patients and you get something significant. It's more likely to be significant than if you have 720 patients. And so things that are really significant and really make a difference, you usually can see it in a smaller number of patients. In any case, we had our first 72 patients that we treated with neoadjuvant chemotherapy. We analyzed the clinical outcome and those predicting recurrence. All of these patients that were included in the study were evaluated preoperatively and thought to need a mastectomy. In our series, 46% avoided mastectomy and had successful treatment with breast conservation. 42% of these patients converted to N0 disease. There's just been a big study that was just published on neoadjuvant. Again, 40% converted to N0 disease, or 30%. Same exact kind of numbers. 18% of our total patients received a PCR, a pathologic complete response, and the HER2 negative, ER negative, hormone receptor negative was the most likely group to receive a PCR. And here was the recurrence rate as stratified by those patients who had a PCR, a partial response, and no response or progression on neoadjuvant chemotherapy. And the same thing happened when you looked at survival. Those patients who had a PCR, molecularly, histologically, appeared to be the same, but the response to chemotherapy was more likely over the course of the 5 years. Again, it took us, first time we submitted the paper, we only had 2-year data, and the subsequent 3 years of trying to get this published, we had follow-up data on those patients. And even at the time this was published, no patients who had a PCR had died of their cancer. Again, these are selected as a high likelihood to have a bad outcome because they were locally advanced cancer and were candidates for neoadjuvant chemotherapy. So the conclusions here is that neoadjuvant chemotherapy response provided important prognostic information. There was a potential to alter the treatment regime. So all these patients would have required a mastectomy had they had their surgery first. After neoadjuvant chemotherapy, 40% of women could have breast conservation. It decreased the mastectomy rate, therefore, and it downstaged the axilla. We found a number of patients who became node negative from this treatment. Being the heretic that I am, I treated some of these patients in sentinel node biopsy only. I know at the time it was heresy, and maybe now we're starting to think differently about it. But we had 2 recurrences, axillary recurrences, in this group of patients who recurred. Both those patients had axillary node dissections when they first presented. So again, I think we need to rethink the role of axillary surgery in all these different clinical situations. I'm now going to talk a little bit about some other biology that I think is interesting and on the forefront of things that are changing the way we treat patients. And then I'm going to end, I tried to come up with a talk that was something for everybody. So just the last few minutes, I'm going to talk about some of our research and show some blots and gels. So you can answer your pages then if that's what you'd like to do. So I want to talk a little first about stem cells in breast cancer. So there's this new theory coming up about stem cells and cancer stem cells and the role that they play in dictating outcome and progression of breast cancer. And so there's a stochastic model of cancer where you have a cancer cell and it gives rise to cells that have heterogeneous types of phenotypes within genotypes and phenotypes in the tumors. They continue to mutate, and that any one of these cells in here can result in self-renewal. But the cancer stem cell model said there's a special cell here called the cancer stem cell that is capable of self-renewing and capable of leading to all these other medium, mid, and well-differentiated tumor cells. And it's these cancer stem cells that give rise to the tumor. And if you could somehow eliminate the cancer stem cell, you'll be able to eliminate the entire tumor. So what's the data for that? Well, this was published first about 13 years ago. I think this was the most convincing data that I saw of this. And they use these markers ESA, CD44, CD24. And the CD44 positive, CD24 negative or low cell population is often used in breast and many other types of solid epithelial-based cancers, solid tumor cancers, to define a cancer stem cell population. And if you take just unsorted cells from a tumor and you inject them into a mouse, you can get a tumor, xenograft form from these primary cancers. And if you put in, 500,000 cells, you can get down to 10,000 cells, you can get tumors. But if you just put 1,000 cells in, you don't get any tumors formed, very rare. So you got to put a lot of cells in. But if you sort the cells first, what they were able to find was that by defining this group, CD44 positive, CD24 low, they also happen to be ESA positive in this model, you can get tumors to form with as few as 100 cells injected. And so this was the first clear demonstration that cells coming from that tumor that were sorted by these different phenotypes and these different patterns of expression on their cell surface define cells with different biology. Some of them can form tumors and some of them can't. So not all cancer cells are created equal. Those that were able to form these tumors have been referred to as either cancer stem cells or tumor-initiating cells. So one of the clinical studies that came from this showing an increase in the cancer stem cell population defined by these markers after systemic therapy. And what they were able to show here is that, again, basal cancers, these luminal cancers, very few of these cells that are CD44 positive, CD24 negative cancer stem cells, very few of those types of cells in luminal cancer. A little bit more in HER2 positive cancers and even more in basal type cancer. But when they actually looked at these different groups, you'll see that these cancer stem cells respond differently to neoadjuvant chemotherapy. So what they were able to show is that before systemic therapy and after systemic therapy, they saw an increase in the percentage of tumor cells that were expressing these markers, CD24 positive, CD24 negative. So these, I'll say, shorthand, cancer stem cells increased after chemotherapy, both in these basal type tumors as well as these HER2 positive cancers. In addition, those individuals who they then saw had this expansion of this cancer stem cell after neoadjuvant chemotherapy had an increase compared to those patients where this population was not increased. If they increase, actually have a worse prognosis. Again, implying that these cancer stem cells are leading to recurrence and leading to metastatic disease. And if you have an expansion of that, it's a marker that your chemotherapy was not effective in that. So the conclusions from this study were that the cancer stem cell population tend to be relative chemoresistant and are associated, when they expand, are associated with tumor progression. And so you need to start targeting the cancer stem cells when we treat patients with chemotherapy. So cancer stem cells are derived, the theory goes, from mutations within tissues of normal tissue stem cells, that is, those cells in our body that lead to the differentiated epithelial cells. They represent a small proportion of the tumor, but they maintain new tumor and result in recurrences. Cancer stem cells have different properties, and they potentially respond differently to different types of chemotherapy. The other interesting thing that I just want to mention is that often these cancer stem cells, when you compare them to the differentiated tumor, have what's called an EMT signature, epithelial-mesenchymal transition. And it may be possible that there can be a shuttling back and forth, that there is some plasticity that goes on. We believe it relates to regulation of certain transcription factors, which I'll show you in a second, that can drive this process of EMT. And these EMT type or mesenchymal now type of cells have these characteristics. And there's this interesting link between cancer stem cell, tumor-initiating cells, and the mesenchymal phenotype that is happening. And the fact that those cells have plasticity implies that there's a potential to be able to treat the patients this way. Well, why is it important to target those cells? Well, here's the difference. If you have a tumor where there's a stem cell and a bunch of differentiated cells, your normal chemotherapy may kill all of these differentiated cells, but if it leaves the cancer stem cell, then the cancer stem cell repopulates and that leads to tumor recurrence. Whereas if we can kill this cancer stem cell, even if you leave the differentiated cells, they'll have a limited life and eventually the tumor will regress. So the last few minutes here, I just want to talk to you a little bit about some of the basic science work that we've done in our laboratory, which relates somewhat to what I've just been telling you from a clinical perspective. We study gene regulation in breast cancer. We have for 25 years longer. And we identified a transcription factor back about 18, 19 years ago. A new transcription factor that had a couple different names. It goes by AP2 gamma. It's also called TFAP2C. And the reason why we got into this is because we're interested in hormone response, and not to go into the many, many years of work that was behind it, but we found this transcription factor. It's a protein, it's in the nucleus, and the bottom line is if you kill it by knocking it out with siRNA, what's shown here, I know you can't see this very well, but this sort of highlights, this is an MCF7 or luminal cancer, and T47D is a luminal breast cancer line. If you knock out TFAP2C by siRNA, ER goes away and all these other luminal markers go away. CD44, as it turns out, goes up. And this happens in all the luminal cancer lines that we've checked, and it happens in primary breast cancers as well. And we have data related to that. So somehow this AP2 factor regulates expression of these differentiation markers, and when we kill it, all of a sudden CD44 comes up. Well, we thought that was sort of interesting. What we're actually able to show is that knockout of TFAP2C induces this process of EMT, epithelial-mesenchymal transition. If you take, this is a MCF7 cell line where we just put in non-targeting siRNA. They look just like MCF7 cells, and for all intents and purposes, they act just like MCF7 cells, no difference. But when we did a stable knockout with an shRNA to TFAP2C, we get these long, spindly-looking cells, and it alters the cell phenotype, and it looked a lot like mesenchymal cells. So we looked at patterns of expression, and in fact, when we compared these non-targeting knockouts with the C knockout cells, all of these markers that were associated with EMT downregulation were downregulated, and a lot of these markers, CD44, E-cadherin went down, N-cadherin goes up, vimentin goes up. All these other markers associated with EMT have now increased, and we confirmed that by Western blot. We knocked out TFAP2C. As it turns out, its cousin, TFAP2A, went up, but E-cadherin went down, CD44 came up. As I said, N-cadherin, vimentin all came up. So it induced this EMT pattern of expression. And we believe, because we did the flow, is that also we had an increase when we knocked out TFAP2C, a tremendous increase in the CD44 positive, CD24 negative population of cells, which is where the stem cells live. And as I said, certainly in breast, as well as in a few other cancers, this mesenchymal type of phenotype is associated with tumor-initiating cells and cancer stem cells. So we began to look at this interesting function of TFAP2C. As I showed you, we knocked out TFAP2C. Its cousin, TFAP2A, actually went up, which was sort of interesting. So we did the comparison. This was published about a year and a half ago in Cancer Cell. We took our MCF7 cells and we knocked out TFAP2A, or we knocked out TFAP2C. And using siRNA, we can knock out each individually. Here's the knockout of A, here's the knockout of C. When we knock out C, all these luminal markers, they go away. When we knock out A, no change. So you could say, okay, A is just dead. It doesn't do anything in the cell. Well, it does. You knock out A, genes like P21, they go away. So TFAP2A is in there regulating genes. It's just regulating a whole different set of genes than TFAP2C. So we said, okay, maybe they have different binding. We published years and years ago that they bound the same sequence, but maybe genomic binding was completely different. So we did chip analysis. This is some ChIP-seq data, and we have obviously thousands of reads. ChIP-seq is just a fancy way to, it's really not that complicated. All you do is you cross-link your protein using formalin. You shear all the DNA, so now the proteins are stuck on the DNA. You then use an antibody to pull the protein down. The DNA is stuck to it, so you're saying, okay, what sequences of DNA came down with the antibodies preferentially? Then you massive array sequence all that DNA that you brought down with the antibody to your TFAP2, in this case TFAP2C or TFAP2A protein, and then you sequence it all, and you get these reads where if there's a lot of sequence, you get a spike. And as you can see, there were these spikes where TFAP2A antibody was located in the genome, meaning that's where TFAP2A binds to the human genome. But look at TFAP2C. It had an identical pattern. They were identical. So the reviewers said, your antibodies are cross-reacting. And we said, well, they don't cross-react on Western blot. They're perfectly, they see each protein differently. No, the antibodies are cross-reacting. So we went ahead and made HA-tagged TFAP2A and HA-tagged TFAP2C, expressed each one individually, used the same HA antibody to do exactly the same experiment, and looked and did by chip analysis. And lo and behold, TFAP2A and TFAP2C, they bind to exactly the same place in the genome, which is exactly the same specificity. But C regulates all these genes, and A does not. So, and the proteins are nearly identical. So we said, okay, we got to figure this out. How are we going to figure this out? They all bind the same place. They're both transcription factors. We know A is active because it regulates P21, but it won't regulate these other genes. Why? Why is it different? So what we did was we took parts of A and parts of C and made chimeric proteins. So we used in this example, here's A in blue, and this was in yellow. I'm sorry, not projecting great, but you get the idea. And this one has the head of A, and this one has the tail of A, and this one has the tail of C, and this one has the head of C. And we kept switching out smaller and smaller pieces of A to figure out what made it look like A and what made it act like C. And then we transfected all these different chimeric proteins back in and looked for expression of, be able to rescue expression of luminal target genes like estrogen receptor and a gene called FREM2. And make a long story short, we narrowed this down to the first 100 amino acids of TFAP2A. You could have all of C or all of A, but if you replace the first 100 amino acids with the other one, it acts like the one that has where that piece came from. So it's the first 100 amino acids of the activation domain. So you could take all of A and just put in that part of C, and it acts just like C in terms of gene regulation. So now, why is that? Again, several years of burning through postdocs, which were just absolutely wonderful people and so dedicated. And we figured out it's a process called sumolation. Again, I won't, just in the interest of time, won't go into it. A lot of experiments. And we came across two different sumo proteins that, if you kill them, completely mess up this difference between A and C. And so we said, okay, is AP2A sumolated? And in fact, it is. And it's sumolated on lysine 10, which is in the first 100 amino acids. So it began to make sense. Here is wild-type TFAP2A, and it's sumolated with any of these sumo isoforms, sumo 1, 2, or 3. Again, not that complicated if you break it down into the steps. Sumo, there are just a group of proteins that your genome encodes. It's about a 15, 20 kb protein that gets stuck onto a lysine, and that process is called sumolation, and that process of sumolation is regulated by some unique proteins. And if you kill those proteins like UBC9 or PIAS1, which are necessary in the sumo pathway, then you kill sumolation. Okay, so what we were able to show is that TFAP2A was sumolated. We made a TFAP2A mutant, K10R, which is we changed the K lysine at position 10 to an arginine, R. When we do that, it's not sumolated. And it doesn't happen in vitro, it doesn't happen in vivo. So that's the simulation point. And what we're able to show is if we took cells where we knocked out TFAP2C, those SKD-C cells, so now C is gone, we killed C. If we put in TFAP2A, again, nothing happens. But if we put in K10R mutant of TFAP2A, now all of a sudden we induce expression of all these luminal genes. Again, showing now by just changing one amino acid so it won't be sumoylated, sumo-insensitive TFAP2A transcription factor, it begins to reactivate all these luminal genes, and which is a process of MET, mesenchymal to epithelial transition. So then we said, okay, the reviewer said, prove it's actually the sumo pathway. So here are two enzymes that are necessary for the process of simulation, PIAS1, UBC9, two enzymes, E2 and E3 enzymes in the sumo pathway required for simulation. Here is the NT cells. These are MCF7 cells. They look just like MCF7 cells. And as you can see, they make estrogen receptor. They do not make CD44, and they make these sumo enzymes. Now we take those cells, and we have knocked out TFAP2C. When we kill C, as I told you, CD44 comes on, estrogen receptor goes away. I've already showed you that. Look what happens now when we transfect in an siRNA to knock out UBC9 or PIS1. If you knock out UBC9, CD44 now begins to go away, estrogen receptor comes back on, and we get an identical result when we kill another sumo pathway enzyme, PIAS1, CD44 goes back off, and ER comes back on. So now we've linked simulation, a transcription factor, and regulation of these epithelial markers in breast cancer. In order to do this in animal models or in cells in a person, you need a drug. Well, there are no real good sumo inhibitors, but there was a paper that talked about this drug called ginkgolic acid, which is a fairly non-specific sumo inhibitor. And what we were able to show was that by treating cells with ginkgolic acid, we could induce those same changes in gene expression of luminal genes and CD44, just like we did when we knocked out this pathway here. Ginkgolic acid had the same effect. Now we got not a great drug, but it is a drug that will do many of the same things that knocking out the sumo pathway will do. Okay, so what does this do in breast cancer? Now here's where being a clinician helps. This breast cancer is a basal breast cancer that came from a patient of mine. I saw this woman in clinic. She had a breast mass, and the history is it was not there a month ago. She had normal mammogram 6 months before. Now she's got a palpable mass. I said, oh, he's probably a cyst, I'll core it. I cored it by palpation in clinic, comes back, basal breast cancer. She goes off, gets neoadjuvant chemotherapy, and she's one of those patients, the tumor just laughed at it. She had tremendous progression, developed nodal disease. The tumor was now filling up her breast after chemotherapy over the course of a couple months. They sent her back. I did a toilet mastectomy on her. It recurred within a month, and she died of disease. So the only silver lining from this is that I took her cells, her tumor, with her permission, and we made a PDX. We made a patient-derived xenograft in a mouse. This stuff kills mice in about 2 weeks, huge tumors. We took cells in culture, and here are her cells. They're almost all expressing this stem cell marker, CD44 positive, CD24 negative. We treated those cells in culture with either ginkgolic acid or a derivative of that called anacardic acid, which is better tolerated, as I'll show you in mice. And we completely cleared the cancer stem cell population in culture. So we said, okay, if this is getting rid of entirely of this CD44 positive, CD24 negative area group of tumors, What happens if you then treat those and put those cells into a nude mouse? And here's what happens. If you treat them with vehicle, the mice die within several weeks. And if you pre-treat those cells with anacardic acid or ginkoic acid, then they don't form tumors anymore. Well, I can reproduce this with SDS, right, if I just mix the cells with SDS. So maybe we're killing the cells. So we inject tumors, then we gavage the animals. We gavage them with anacardic acid or vehicle. And this is the Iowa 1T is the cell line derived from this poor patient. BT20 is another basal breast cancer line that you can get from ATCC. You can get this by ATCC now too. They have it in stock. We gave it to them. And if you gavage animals with anacardic acid, no tumor formation, either in IO1T cells that came from this patient or BT20 cells. If you just gavage them with vehicle, though, they form tumors normally. So here's the model that we have, that we've developed with this. TFAP2C is active in many luminal breast cancer cells, and it's required to maintain this luminal differentiated state. TFAP2A, because it is sumulated, if it becomes sumulated, it is completely inactive with regard to this EMT transition. But if you inhibit the sumo pathway, either by mutating the sumo site of TFAP2A so it can't be sumulated, or treating with a small molecule inhibitor, or killing the pathway, this unsumulated TFAP2A is able to substitute for C and induces this transition from a basal to luminal, or MET, from a mesenchymal to a luminal phenotype. And we believe that this will have important implications for treatment because these cells are it's also affecting the cancer stem cell population. So I want to acknowledge, again, NIH that supported much of this work through R01 grants and a T32 grant in surgical oncology. And if any of you are interested in spending some time at Iowa during your residency, please talk to Dr. Chen and we'll be happy to consider having you come and work on our T32. Maria Bogacek is a postdoc in my lab. She's the first author on the cancer cell paper and has done a lot of the sumo work. Mikhail Kulak, again, a tremendous molecular biologist, has done some of the chip work and some of the other patterns of gene expression work that you saw. George Woodfield was in my lab as a research assistant, keeps the lab running, and also has done much of the early chip work that I showed you. Jungmin Park is a MD PhD student at Iowa, did some of the work related to the early work on EMT that was occurring that I showed you, and he's did his PhD in my lab and is now on the clinical rotations and is interested in surgery, so maybe you'll be seeing him as an intern applicant in a year or so. James D. Andrade is a surgery resident at Iowa and has done this work as well as some other work related that I haven't shown you related to RET and its role in inducing patterns of hormone response. Allison Lorenzen is another surgery resident at Iowa who's on the T32 and is in the lab currently and doing some amazing work that I haven't had time to talk about, which has not been published yet, but relates to being able to pre-treat animals with this anacardic acid early in puberty of those animals and inhibiting tumor formation in an activated new model. And Vivian Wu, who's now Vivian Gu, because she got married, is another PhD graduate student in my lab, again, doing some of the animal models and keeps the whole animal colony moving forward. I don't know how she keeps track of all the breeds, but done a tremendous job. So.